everybody. A very good afternoon again. We are going on to our next podcast. So today we are going to talk about something interesting and very much closer to our heart. It's about cost, right? Yeah. So we all know that healthcare cost is an ever increasing cost, whichever country you live in, whether it's Singapore or globally, right? And it will always, every year on year, it always increase. And of course, in a small country like Singapore, a very complex and complicated and advanced healthcare system. So obviously, it's even more relevant to us as practitioners, but it's also very relevant to our audience who may be the one receiving the healthcare. So I thought it is useful for us where we have GPs, we have specialists sharing from our different experiences and point of view to look at and unpack some of this thing about the issues about healthcare costs. Right. Okay, so maybe we first look at the some of the factors affecting the bill size, right? So maybe we touch on public and private differences. Yeah, can start with any one of you actually. Yeah. Whoever is more angsty.
Well, I think the difference between public and private healthcare in Singapore, I feel that people need to understand that actually manpower cost is really the same in both public and private, because doctors can choose to either work in the public sector or in the private sector. So that means that a lot of the costs, as wages go up, as manpower costs go up, the cost will rise both for the public and private side. The only reason why private bill sizes may be a bit smaller is because of the general subsidies that the government gives for people who seek care at the public institutions. Whereas for private institutions, we don't have that much of a subsidy increase over time. And so people do feel that private primary care is getting more and more costly as time goes by. And we are looking forward to a revision and any changes that MOH will want to announce when it comes to the subsidies that they are providing for private GPs. I think they are starting a little bit. They are trying to help us with patients who are taking multiple medications, and through their Healthier SG scheme, we are able to order subsidized drugs from the public so-called purchaser, and so we can offer that to our patients and to help to moderate the rise in the healthcare costs.
Right.
But that's only addressing the drugs part, which is the main part is still the manpower cost going up over time.
Right. Yeah, in fact, that will actually open up another few podcasts, talking about the actual cost of running primary care. Yeah. But without going into that in detail today, let's listen to John as a private specialist. What do you think?
Have you guys talked about Healthy SG already, just now?
No, we didn't. Yeah, we didn't. Healthy SG is a scheme, but because Healthy SG doesn't really talk about or address particularly about cost. At least not at the primary care sector.
No, it's just that Kenneth mentioned Healthy SG.
Yes.
I thought maybe for our audience we could just
briefly talk about
what for specialists. I also not too sure what Healthy SG is all about.
Yeah, sure. I mean, I can share with you about Healthy SG. Yeah. So Healthy SG is a really complex scheme. There are many limbs to it. The first one is actually preventive health. So it actually funded a first check-in with our GPs, and that allowed us to promote health screening, for example, for patients who have not received their health screening. Secondly, also their vaccinations. And so there was a large uptake in terms of influenza vaccinations, pneumococcal vaccinations among our older patients.
Is there age criteria for health screening and vaccination?
Yes. So there are certain criteria for age, certain criteria for example, vaccinations, their medical conditions, or whether they have also hit a certain age.
And it's for citizens and PR?
It's for citizens and PR, although citizens receive more subsidies than PRs. Yeah.
And it's for, currently the rollout is for those who are above 40 years old. Yeah. Are you 40 already?
What do you think?
Have you enrolled with a GP?
Not yet.
Eventually.
Okay, sure. Yeah. Difficult choice, but I'll choose one. And so you mentioned about vaccination screening. What's the other limb?
Yeah. So and that's not the end of it. For the preventive part, we are also doing things like risk factors. So analyzing your height, your weight, your BMI to tell them whether they are overweight or obese, promoting exercise and diet, as well as smoking cessation. So those are all in the preventive component. The second part of it is also the chronic care, right? So under Healthier SG, we are able to order subsidized medications from this company called ELTS.
Yep.
So the amount that we charge our patients will be capped at a cap price from MOH, and then when we purchase the medicine, let's say to stock, it will be also at the price that MOH has set. And so in that sense, patients are assured that the amount that they are paying is comparable to that at the polyclinic for their medications.
So what you're saying is, as a private GP, you own your own clinic and business. You have to get the medications from ALPS and sell it to the patient at a fixed price. So you can only get a fixed profit.
Correct. The margin is
But
fixed.
of course, that benefits the patient. But does the government give you any subvention of subsidies to do this to benefit the patient?
No, unfortunately, we don't. The patient benefits because through this scheme, they are getting, like what you said, a fixed price. Secondly, of course, the government also subsidizes based on their income, whether they are CHAS Blue, CHAS Orange, CHAS Green, PG or MG, they are getting a fixed percentage of their medication bill.
Right.
So that helps, especially if you are taking multiple medications.
So, Kenneth said it is not no subvention to offset. It's not exactly no, but there's an amount called CEG, the chronic enrollment grant.
Grant.
And this amount is, I can't remember the actual amount, but it's an amount based on the number of chronic patients that's on your list in your clinic. Yeah. So most GP find that this amount is still very small compared to what they could have lost. So that's why there's a lot of negotiation between the GP sector and MOH. We're trying to refine the scheme. So a lot of it is work in progress. Yeah. So whether you will get it such that you reach the same level as, say, a private patient, then we are really not sure, because a lot of things are still very fluid. Yeah. But at least we are in the talk.
Hey, so
Yeah.
have you ever had patients come in and say, I don't like this drug. It's not good for me. I want better ones. Then they are expected to pay a private rate.
Yes, they
Right.
That's right.
Yeah. Okay.
Yeah. So patients have the autonomy to decide whether they want subsidized drugs or they want the original drugs. Of course, they cannot request for original drugs at subsidized price.
Yeah.
I mean, that's just pure not possible,
Sure.
right?
Yeah.
But we all have autonomy. But of course, the first layer is always the autonomy at the patient level.
Yeah.
Then after that is the level of the GPs.
So
Yeah.
so this, what I'm hearing now, creates a nice segue into the healthcare cost, because it sounds like you don't have so much freedom in setting the price for your drugs, because you have
Yes.
to follow Healthy SG. But yet the rising manpower cost, the rising rental, and the other cost, inflation, that really makes it hard actually to be a GP, isn't it?
No, it is. It is for those in the private sector, because we are not sponsored by, in the public sector, nor are we the same as those clinics that are supported by charities.
Yeah.
Right. So we are pure commercial. Pure commercial. Every single cent we have to earn it. So we will have to find ways to earn it. Of course, different GP clinics have different ways. For many of us, we try to upskill and we try to provide better quality of care. And with that, we actually charge a higher consult. Now, some of this consult is actually reimbursable under the CHAS scheme. So that makes it affordable for our patients. So really different stroke for different GPs, and really different patients when they look at the bill size, when they look at the components of the bill, when they look at the out-of-pocket payment, that's what they decide who to go to. Yeah.
So it's kind of a nice way that the government is creating a program, Healthy SG, to cut down the overall healthcare cost.
Yes.
But I personally feel it is difficult when you have, in a world, especially after COVID, there's rising cost, rising rental, and you're trying to keep everything. If you're trying to keep healthcare as effective as before,
Right.
but you're trying to keep the cost down.
Yes.
And they certainly, obviously, cause a lot of pressure on everybody, isn't it?
Oh yes, it definitely does. Yeah. Right. Yeah. Since we are talking about primary care mainly. How about at the specialist level in the private world first?
So as I mentioned, I think since COVID, there's increasing rental cost.
Right.
I would say probably after 2020, 2021, the rental cost for renting a unit probably will go up by 10% per annum.
Wow.
Year on end. I think and then again, there's also, of course, in public hospitals, all the nursing staff, all the doctors are getting pay rise. And I think the latest one from the news was 7% for the nurses, isn't it? So of course you're gonna have that equivalent pay rise for the manpower cost as well. And I guess it goes with any kind of business currently in Singapore. The rental is going up, manpower cost, salary is going up, inflation is rising. So yeah.
Right. I think for the GP sector we are rather similar in terms of rental issues as well. Because lately we do have news that some of the new HDB rental has gone up as high as $52,000 a month, right? Yeah.
For I think just for the audience, would you share how big the size of this 52,000?
It's 50 square meters, which is roughly about 500 square feet.
500 to 600 square feet.
Yeah, it's
right?
very small.
Very
small. Yeah. And that's 52,000 per month. I really do not know how the person who leased it is going to make it. Yeah. And you really can't pass on the cost to the patient 100%.
Because your pricing, your consultation, everything is fixed. What you alluded to earlier.
Well, it's not really fixed. Because consultation is not really fixed, but if you charge too high a consultation fees, and then obviously patient will come to you.
Correct.
Right. Yeah.
Yeah.
And then the other pressure, of course, is manpower cost. Manpower cost at the GP level, at the moment, we are really very basic and very, I like to use the word Flintstone, right? We are really caveman kind of prices. So we are looking at very basic, employment for clinic assistant and not really having nurses or any of the allied health professionals. Yeah, so you compared to say in the polyclinic where they have nurses, the pressure from wage rises will probably be a lot more. Yeah. Especially now post-COVID, a lot of the nurses have been redeployed, or some of the foreign nurses have gone overseas to work and all that. So that adds a lot of pressure to the wages. Yeah. Right. Okay, so there's one portion of the total bill size that we talk about affecting healthcare costs, right?
Yeah.
Now, so how about from the point of view of the public, right? Let's say, for example, if they want to go to either private or public sector for specialist care, obviously, I guess in the public sector, there's different ward classes.
Correct.
And how about in the private sector? Do they get to choose what class or ward do they have?
I think in general the ward class is the same.
Yes.
Unless you really want to go a premier kind of lounge like the presidential suite.
Right.
Those ones will cost just like your Marina Bay Sands presidential suite, right? Probably $10,000 a night or something like that. But in general, I think the charges for the private hospital rooms are pretty much the same. Either you are single bedded or 4-bedded rooms.
Right. Then will there be a difference in quality of care between the president suite versus the?
Well, I guess those are for VVIPs, so yes, the cares will be. I mean, you get the same nursing staff, but you probably a bit more attention to detail. But I think the changes are subtle in
right.
But I know that in public hospitals you can have A class,
Yes.
B1,
Yes.
B2, and C class.
Right.
So my understanding is that in a restructured hospital or public hospital, when you have class A and B,
Yes.
your room is nicer, and you don't have share bathrooms.
Right.
So for example, your class A will have a single bed to one toilet.
Right.
Class B1 will be maybe 2 beds to 1 toilet.
Yes.
And B2 is gonna be 4 beds or something like that.
Right. Yeah. Just for our curiosity also, I want to ask Kenneth, how do you decide, or how do you help your patient decide where to go for specialist care, whether it's private, whether it's public, and if it's public, which hospital, why, what are some factors,
Oh wow.
and whether private in the public hospital or public, subsidized care.
Well, I think when a person is looking for healthcare, generally I look at the patient and I see what matters to them.
Yes.
Yeah. So a lot of the times they are looking for a doctor that they can trust. And so I would prefer to refer them to specialists I've worked with before, who have reasonable charges, who have high quality, medical care, attention to detail, and do not overcharge. So then I would recommend, specialists that maybe I've met at our GP Plus cooperative meetings, or my classmates whom I've known for many years, and I know that they are doing good work. So that would be my top recommendation. But of course, a lot of patients they are concerned about healthcare costs, or they have already purchased some form of insurance that will be restricting the kind of specialists that are accessible to them. Yeah. So for those who are looking for private specialists under their panel, then generally I will take a look through their panel and guide them in a certain way. But some of my patients feel like they would want to make their own decisions. I think it's nothing wrong to make your own decisions, but you are missing out on a very important resource, which is our experience. Many years in primary care and seeing patients with the same health conditions. You're missing that experience that we have helping other patients with the same problems. And then lastly, when you talk about public healthcare, generally you have two options again. You can actually go after a named consultant, and I do recommend if you can swing it, to go for a named consultant, because that will determine who is the one who's giving you the medical advice. If you can't, then it will be the general queue, right? And that will mean that your specialist or your consultant will be randomly assigned depending on who is on the roster for that particular clinic session. Yeah, so those are all the different levels, and generally we try to guide our patients through the process.
Yeah.
Sometimes in the subsidized route, you may or may not get a specialist. You may get trainees as well.
Yeah,
like
exactly.
registrars. So there's a bit of a hit and miss.
Yeah.
But certainly these registrars are all supervised by the specialists in the public hospital.
I wonder whether you can say this, you can cut this out. But for some of our GPs, right, who actually know the public specialists quite well, and we really see people who are in need, that need an urgent or earlier follow-up with a specialist, then sometimes there can be some things that we can negotiate with the public specialists to see them a bit sooner.
Is that right?
Do you do that?
I have not done that before.
You've not done that. I do, for rheumatology, for example. They don't have their DMARCs or their things. So I know the Sengkang RAI. Then I will actually message him to say, can you help me see?
Who's that?
Huh?
Who's that?
This Kushianto, something like that.
Okay.
Yeah.
Okay, so
Then
having said that,
dermatology also. Like some of my friends who are now senior consultants, they will pick up the patient from the generalist.
Okay, having said that, actually I don't think we need really to cut that. No, but seriously,
Controversial.
Because only people who've seen us for many years, and then we will say, actually we can help pull a bit of
Suddenly every 5 calls from GPs and please help me.
Well, I mean, having said that, I know that in healthier SG, maybe called part 2 or part 3, so we are trying to actually make referral more seamless between public sector as well as the private GPs. So there's this thing called virtual professional consultation. So what it means is basically there's always interaction between the GPs and the specialists in the hospital based on the discipline. Yeah, so there's always a group chat, a general group chat that the GPs can post questions, the specialists can advise the GP and so on. So these are all not name basis, but there's also a version of it which is being tried out in the polyclinic. So that might be the one that you're talking about. Yeah, so they actually have done it for a couple of years. So what they can do is that they go into a more secured platform where they discuss the patient, and if need to, the specialist can actually arrange to see the patient earlier, because the queue for the general queue may be very long, but the specialist in the hospital may not want to miss out those urgent ones as well. So that sometimes that happens. But I think that one is mainly in the polyclinic at the moment, but in future it will be coming on to the healthy GPs as well. So wait for that.
So in terms of healthcare costs, we know that it's just like any kind of commercial business. There are three factors which you need to fulfill, right? You cannot get things which is product which is or buy something that is good, fast and cheap. So like for example, if you eat at McDonald's, it's cheap and fast, it's not gonna be decent food. So it's the same thing I personally feel applies to healthcare costs, particularly in private. In private, healthcare costs is not cheap. I think can be done quite fast. So sometimes you can get CT scan and scope within 1 or 2 weeks, as opposed to maybe in institution, you may take weeks before someone gets an endoscopy. Quality, I think, variable. It really depends on whether the person is good or not. But what do you guys think about cheap, good, and fast?
I mean, I certainly agree with you. But I thought the definition of quality differ from person to person.
Correct.
So use the example that you talk about a certain fast food chain, right? We don't mention names, right? But actually, to be fair, I think the quality is acceptable at that price point. Right? But we cannot expect fine dining standard at the fast food chain. I mean, that's totally unreasonable. So similarly, when you look at healthcare costs, especially I can say for my own practice, I make sure that I see the patients sufficiently. That also means that the consultation can be very long sometimes, and comprehensive, looking at NEHR, looking at different things, discussing with patients, and even talking to the specialist at the same time when I'm talking to the patient. So I think John and I work quite closely with some of our patients that way as well. So with that kind of consultation, I don't think I can charge anything lower. If not, definitely, not only is not able to earn money, I probably go bankrupt very soon. Right? I mean, this is it's time, right? And I can't feed my staff if I were to charge low. So therefore, I must confess that I don't charge cheap. In fact, I tell everybody I don't charge cheap. Even patients, I apologize to them that I can't charge cheap, and they understand that. So I think a lot of times patients know that the quality is there, they're willing to pay, and but you need to be upfront with them. You cannot shock them with a bill that is out of the world when they are not forewarned, right? I think that's important. And of course, I feel that, especially at the specialist level, sometimes a lot of it is not just forewarn them, but actually let them make the choice. They must have the autonomy to decide for themselves. Some people may be willing to pay $3,000 for an iPhone, but not willing to pay $3,000 for a scope, for example. Right? But there are people who are willing to forgo the phone totally and save the money for a scope. So really depends on people how they value quality.
Correct. It depends on how they value their health or their
the other wants and needs.
Their tech wear.
Yes, that's right.
For example, I've done colonoscopy for patients removing biggish polyps.
Right.
Before I do that, I always tell them that colonoscopy can be expensive. Are you okay to go ahead?
That's right.
Especially those people who have no insurance. And I always tell them it can be quite expensive. Then I will say how much, and then so I give them the range of the price. And that is just to build the expectation that I'm not here to scam you, to rip you off, but this is the standard cost. I think you need a scope. Unfortunately, you don't have insurance. And obviously, a lot of these patients come from restructured hospital. They say, I cannot wait for 3 months for the next appointment. I really need to get things done.
Right.
So I always tell them, I'm so sorry, but this is the cost. Are you okay to go ahead?
Yeah.
And most of the time, I think a lot of private specialists out there also, they will see the patient in front of them and they will give appropriate discounts or concessions because we know for some of us the life is a bit tough and we always try to help. I think at the end of the day, we all doctors, we all try to help our patients.
Right. The other thing I thought maybe Kenneth can chip in as well. Sometimes I decide or help explain to the patient why certain route is better. Example, like you say, urgency of the diagnosis or management. Sometimes to allay the anxiety, and sometimes it's also based on that condition itself whether we expect certain highly cost procedures or for that matter a very long length of stay, right? So Kenneth, do you do that? So when you refer a patient to the hospital, whichever private or public, and sometimes a patient may want to go to private, but because you sort of suspect that the condition may need a very long length of stay for care or very expensive procedures, what do you do then?
Generally, I would advise my patients also, depending on the urgency of their condition, whether they can wait. One good example is a lot of patients go for their diabetic retinopathy eye screening, and then the waiting time for some public institutions can be up to 6 months or 1 year, and that's actually beyond what is recommended by the eye specialist himself. So then these patients will refer them to the ophthalmologist in private. When it comes to hospital stays and longer courses of treatment, of course, then that's when understanding of the specialist that we're referring to is helpful, because when we refer to a specialist that we know and we trust, then we will avoid a lot of the potential pitfalls of a long stay or over servicing or all sorts of issues. Then some patients, whether they will benefit from a public hospital versus private, actually, to be honest, I feel that both the quality is actually pretty good, pretty decent. So but of course it depends on the patient's ability as well to pay. So if I feel that they may face in some financial difficulties, then public hospitals are probably the most cost effective or cost saving kind of place for the patient.
I think I agree with you, but I think on top of that, public hospital have this thing called MediFund.
To help them.
It's 3M, right? So MediFund, whereas private hospital doesn't have that. So the desperate ones, sometimes we still advise them to go to public hospital, then get themselves into the subsidized class. Then if really worst of the worst, go to see a medical social worker, try to get MediFund to help. So there are many ways actually in Singapore, except that some of these ways are actually available only to the public sector and not the private sector. So sometimes I advise my patient that way as well. So while we look at all these costs, there are a few other components actually. So that will actually increase the bill size. One is of course investigations. Another one is the consumables, and then the last one is medications. So let's tackle one by one. We start with Kenneth first, then we talk to let John talk about it from the point of view of the specialist. So we start with investigations. So what do you do? Let's say a patient, give an example, maybe a person have backache, chronic backache, and you need the patient to do an MRI, for example. Where do you send the patient to?
Generally, if a patient has backache, I think they will benefit from further investigations. Then we would definitely look at I usually offer them a range, because there are various private imaging institutions, in Novena, Orchard. So, and of course, I do have some preferred radiology centers. And I usually tell the patients that these are the options you have. I do prefer one over the other, and I prefer one over the others, not because of the cost, actually they are a little bit more expensive, but because the quality of the reporting when it comes back is higher. I'm able to tell you with more certainty what the problem might be. So that's how I counsel them. The second type is, of course, some patients would prefer to use their insurance, and through the insurance they may have to be seen by a specialist before they can go for an MRI. So then that would be the other route. So generally when it comes to investigations, I also feel that a lot of patients are in primary care are really under investigated. They're having a problem, but because they feel that primary care is supposed to be cheap or low cost. So when we recommend necessary investigations to sort of figure out the problem a little bit better, a lot of patients just reject and say, send me to a specialist. Actually, if we had done those investigations right there and then, we could give you a better answer, or even direct you to the more appropriate specialist.
Yeah.
Because when we don't have enough facts, then sometimes you may actually go on a wild goose chase and go to multiple specialists.
That's right.
Yeah. So investigations, I think, are not really a big driver of care. In fact, they're actually more of like tools that actually help us streamline and direct you to the right areas for help.
Okay. Yeah, so I had the same problem as well. In fact, sometimes for investigations, I will have to use I would use the public sector as well, because patients will find it difficult. Because some of this investigation, like MRI, actually they're not cheap. They're really not cheap. Or sometimes certain conditions, like autoimmune conditions, they need multiple series of investigations. Each one is not expensive. But you do that every month for one whole year, it's going to cost a little lot. So things like that. Then of course insurance. In my clinic, I do not accept any form of insurance, so it doesn't really affect me in a big way. So whenever the patient wants to use insurance to pay, I will just have to refer them out to somebody that the insurance company so-called dictate. So unfortunately that's not ideal. I don't quite like it, but I mean, for the sake of the patient's pocket, right? So for John, so as you know, sometimes I refer patients to you because there are certain investigations, just like what we said, right? Sometimes the insurance may not allow the patient to pay. So from that point of view, how do you try to order investigations to help the patient without bursting their pocket?
I think I will always say this is the best. For example, if someone needs an MRI, I will say this is the best, but it's gonna be more expensive. And I'll tell them the pricing range between a CT scan and MRI. And I say alternatively we can do an ultrasound. I will tell them my recommendation is do X and Y and Z. And they unfortunately, because if insurance doesn't cover, then the most important thing is the patient need to decide financially what they can take on in terms of the cost or impact. But I think the cost of the scans or the imagings in private is not gonna be it's probably on par or if not slightly cheaper than your public hospital. Slightly cheaper. I guess because your public health institution, they need to cover for the electricity, the manpower, the other miscellaneous costs. But in private scans are cheaper if you want to fast. And quality is very, we say healthcare quality is variable, but you gotta know where to go. But it will certainly be cost is also quite good.
I observe a phenomenon. I'm not so sure whether it is rampant, but I see that in the last couple of years, maybe for the last 10 years or so, 5 to 10 years, I find that a lot of doctors, both public and private sector, so a lot of times for fear of missing out something, so generally they will order a lot of tests. So I see that in both private and public, and it's really quite opposite from what Kenneth said. Primary care we don't investigate, or people don't expect us to investigate. And to the extent whereby sometimes I also wonder whether it is a matter of protocol. It's like I've seen patients with liver issues since they're liver specialists, right? So they're inpatient. It start off with an ultrasound of the liver. The next day they do a CT scan. The next day they do an MRI. Of course, in that sense, there must be a certain reasoning which I'm not privy to it. But from the look at it, it looks odd because you're like doing level to level, one day by one day, right? I can't really understand the logic behind. Have you seen that, and what do you think is happening?
If I can understand this correctly, I think the reason for that is obviously, so there are three modalities for the audience who don't know. There's ultrasound, there's a CT, and an MRI.
Yes, that's right.
You may or may not inject dye or contrast.
Oh, yes.
Now, I guess in a public hospital, a CT scan there'll be a longer queue. So if I order today, I may get it not 24 hours, probably 2 or 3 days later. MRI could be for 3 or 5 days.
All right.
Ultrasound could be done the next day.
Okay.
So perhaps because of the waiting period, they say, let's get an ultrasound first.
Right.
And an ultrasound say, the report may say, there's an uncertainty regarding the spot. And they say, okay, let's go ahead and do a CT. Because MRI will take even longer, so let's do a CT. So sometimes when you order a scan, there may be about 5 to 10% chance that you need an extra scan. So in terms of the level,
Yeah. I've observed that actually.
Yeah.
Rather common, I must say. Yeah.
But I also observe some patients, they maybe you offer them an MRI, which is the recommended modality.
Yeah.
And then they may ask the specialist, can I do a cheaper scan? And yet they still want the accuracy of an MRI and the quality of an MRI.
Correct.
How do you deal with such patients?
I would say, okay, if you really want, we can try this, but it's not recommended because it may not give you the best image.
Yeah.
I think so. They also bring to me and ask me.
And then,
you haven't done the right
then when they say they want to do X-ray, and it comes out, and they say, doctor, how come I don't know? How come you still don't know what's up? I said, well, this is the X-ray. And then in my mind, I was thinking, see, I told you. But I think it really, I think trust goes a long way.
Yes.
To develop personal relationship with your doctor, have a trust, and the doctor also will tell you very honestly what is the black and white, what is the reality here in terms of the scan, why we cannot give you the answers that you wish one scan can fix.
Right. I have also observed some among patients, public and private as well. Sometimes they may, like you say, order the MRI and take 4 days to get the appointment, right? If they're inpatient. And then if they're outpatient, the appointment may come 2 to 3 months later. So they opted to stay in the ward for additional 3 days. And these 3 days, probably nothing is done. But for the sake of an earlier appointment, they actually stay in the hospital. Is that common? I've seen a couple of them actually.
In public hospital?
Both public and private as well.
Haven't done that in private because the bill really racks up. In terms of the insurance anyway, if you are hospitalized, there's a 6 months to 1 year coverage anyway.
Okay.
So whatever outpatient scan you do after the hospitalization is reimbursable.
Right. So it doesn't matter for them to actually stay on or not. Right. Yeah. Kenneth, have you seen any of this like that?
No, not really. I've seen people who are hospitalized for the purpose of claiming insurance just for a scan that can be done outpatient.
Private, right? Private insurance.
Correct, for private insurance.
Oh, okay.
Unfortunately, that's what they say, the buffet syndrome. They get admitted. I want to see a neurologist. I want to see a heart doctor.
Right.
I want to get my MRI of my spine.
Yes. I think I have seen also patients that was kept in the ward for another additional 2 or 3 days, waiting for the surgery. Now that one I can kind of understand and rationalize because the OT space is this much. If you go home and you come back, your condition might change, your pre-op investigation you must redo again and all that. So it doesn't really make sense. It's probably okay. But for investigation, I rarely have heard of it, but I just couldn't rationalize why that has been so. Yeah. All right. Yeah. So there are 2 more portions to the cost of healthcare in that sense for the bill size, right? One is consumables, and the other one is medication. Maybe you talk about consumables before I touch on medications. Consumables will be things like, probably not your specialty, but some of the others, right? So for example, orthopedics, surgery, and then cataract surgery, when you put the lens in, and those. Yeah, so those are also costs added. And I suppose, I'm not so sure, we should have an orthopedic surgeon or eye surgeon here. I suppose different joint replacement, they have different quality, different material use and all that.
Yeah.
Have you heard of anything like that?
Yeah, so one of the components of the hospital bill would be consumable. It depends on what you use. For example, you go into a scope. They will need oxygen nasal prong.
Yes.
Your bite block. You'll need the sheets for the bed. Suction tubing.
Yes.
Biopsy forceps. All those things are all consumable.
Right.
What does it mean? It means that once you use it, you cannot recycle. You have to dispose it.
Yeah.
So these are medical consumables, are necessary part of the procedure or the investigation or the treatment of the patient. So those are unescapable, I think.
Right.
Those, but of course, just like any other business, of course, there's a degree of markup for
Yes. I mean that is reasonable, right?
Yeah, reasonable.
Yeah. Right. Yeah. In fact, then we talk about, for the same reason, we talk about medications. So in terms of medication,
sorry.
Yeah.
So consumable
Yes.
would be like you go into a restaurant and they give you weight towels and they charge you $1.50.
Right.
Yeah, and they will charge you the pickles and achar, charge you $3.
Oh.
So they can consider that as consumable.
Right.
Yeah.
Okay, so you're moving, because my concept of consumable, I'm talking about the big items. I'm not talking about the peanuts,
relatively speaking, these are
uh,
consumable. You need it, you need your weight towel, but they like, might as well charge you.
you can bring your own, is it?
True.
But I think the practice of medicine has also changed in primary care.
Right.
In the past, many more GPs would actually own autoclave and will sterilize their dressing sheets, their cotton pads, their Gary pots and all that.
Yes.
But over time, because of maybe higher requirements in terms of licensing, terms of ensuring sterility, then people are now more purchasing more of these sterile dressing sets from the major manufacturers. And so that's providing a higher quality of care to the patients, but also that entails some increased costs when it comes to consumables.
Yes, that's another podcast, Yeah. You know, I help the younger doctors open clinics, both GP and specialists. One of the tricky thing is deciding whether you have autoclave or you buy the disposable set, right? The disposable set is actually a lot more cost effective in that sense. May not be cost efficient, but cost effective, because basically you just sell it to the patient, as in cost it to them, and then you just discard it after use, right? So it's a lot easier. Because maintaining an autoclave machine, you need to get the licensing, you need to get the inspection done, and what if the machine spoiled, then you got to get it replaced. There are 1,001 things you have to do it.
So does the cost fall to the patient?
Okay, the cost does fall to the patient, but actually it's less to the patient. The disposable kits are more expensive per set, per unit. But overall, to the GP setup, it's more worth it because you put in a lot less effort. And the inspection site is definitely much less because you don't have a machine. You don't have to look for MOM, because just HSA and that's it, because for that one, you have a pressurized machine in your clinic. You have to get MOM for inspection, which is a totally different ministry. So it's a lot of headache actually.
Sometimes it's hard to explain to patients as well that you're saving them money by doing an autoclave and having all those things on site. Because it actually increases your procedure fees. Right? You are spending more time, more effort preparing all this equipment that is reusable. So your procedure fees go up. But you are not charging them a consumable fees. Whereas for those clinics that use consumables, then they are charging a professional fee for the procedure, and then they get to charge all the consumables on top of that.
And it looks reasonable, right? Because too many items inside, so it looks reasonable, right? Whereas you put one set meal, it doesn't look reasonable.
Like dabao box, 20 cents for one box.
Correct.
Dabao box.
Correct. So you itemize the.
You want extra chili, 20 cents.
A plastic bag. You go to NTUC now, you must pay for a plastic bag.
But when we're using the autoclavable instruments, they're actually higher quality, right? Because they're all well made.
Talking about that, true. That's true too. Because sometimes you do minor procedure. It's very frustrating to get the disposable ones. They're so flimsy, right? Plastic and flimsy. You can't even hold anything. So it's terrible. It affects our own standards as well. But patients don't see those things. That's right. Okay, so the last item we could think of was actually the whole idea of what is that? Medications. That's right, medications. Right. So how do you view the cost of medication? actually all of us actually sell medicine, which is a bit unique to our country. Most other first world health system, they would just write a script and then send it to the pharmacy to fill it. So that is what other people do. Obviously, our system has its merits because actually it's a lot easier for the patients. It's one stop, and in general, I understand from the pharmaceutical companies actually they actually sell it lower to us so that we can actually pass the savings to the patient. So these are values that sometimes patients don't see. But on top of that, there is also this whole debate of whether original versus generic, especially talking about cost. We're talking about this generic versus another generic, the country of origin and all that. So how do you interpret this and how do you help the patient understand this?
I go first.
One more question. How do you stop? Which one do you choose to stop?
Okay,
the medicine? Yes.
So I feel that this discussion about medication, right, is like discussing tires for F1 cars.
Okay.
So a lot of people are looking for the cheapest tire for the F1 car, but the most important is actually the driver. You want the best driver, right? And so when it comes down to medication costs, actually the most important is actually the doctor or the specialist who's advising you on how to take these medications, what are the side effects to look out for, how do we monitor, make sure we are hitting the targets. And so if we are, and so that part is actually a more important part of the conversation, right? If you are not monitoring, then any medicine you take will be fine because you don't know whether it's helping you, whether the quality is up there, or whether that's the right medication for you, as opposed to your friend or someone else who told you that, if you have high blood pressure, you should take this, right? It should be individualized.
Yeah.
So when it comes down to actually discussing between generic and branded medication, the truth is that branded medication has gone up in price quite a lot. I think most of us receive letters from the drug companies
every year
that prices have gone up 5 to 10%. So I think, and that's on an annual basis. So patients should expect that the prices go up over time. Generics is a way to help to control those costs because for generics it's a more competitive market. But in a competitive market, of course, there are also challenges because the quality levels may vary from company to company and from batch to batch. So that's where doing the blood test, seeing your doctor regularly is a way to do a bit of QC, right? To make sure that you are hitting the treatment targets. Yeah. So when we talk about Healthier SG, when we talk about the central purchasing of drugs, I was very amused to find that in the current system, atorvastatin 10 milligram is from one company, 20 milligram is from another company, and 40 milligram is from a third company.
Okay.
So just because you do well on the 10 milligram, I'm not sure whether when you increase in dose to 20 milligram, the results are predictable, right?
The purity of the ingredients
Yes.
is consistent.
Yes.
So I've got patients who, after I increase the dosage, then they come back and say, I didn't see an improvement in my LDL. And then I switch them to unfortunately, my own generic rather than from the government portal.
I've seen that also.
So
I blame it on the patient not exercising it.
So there are many possibilities
Yes.
when it comes down to generics, and so that's why you need a good driver.
Yeah.
How about a specialist?
So in my clinic, I keep generics and branded, but different medication. For example, I will have generic rabeprazole, but I will have branded stronger, more potent, newer medications. It's just that I found that things like generic omeprazole, which I'm sure you guys use a lot, when it's made from overseas, foreign countries, it's, like I said, the purity of the ingredients is not so good. Sometimes people take it, there's no effect. And so omeprazole has been around for at least 25 years.
Yes.
25 years. So although it's cheap as chips, but again, you gotta say a cheap thing may not be so good.
Actually, it's not that cheap. Actually,
Is it?
it's not expensive, but it's not that cheap.
How much is it per capsule?
I can't remember, but I think at least 40-50 cents per capsule.
Yeah.
And this is not selling price. This is
Yeah.
cost price.
And then I guess with the branded one,
Yes.
you know it's more potent. Potent means that
The efficacy.
yeah, efficacy.
Yes.
You know, if omeprazole is +1, this potent one may be +8.
Yeah, yeah.
So there's a different levels.
Yes.
So you want your problem to be fixed faster, then I always give more potent one.
Yeah, yeah.
Cheaper ones I know it's good, but I would leave it for patients who have cost concerns.
You see, the tricky part about dispensing at our clinic is this. Patients a lot of times equate their speed of recovery to your standard of care.
Your skill.
Your skill and your standard of
whether you're
care,
good or
right?
not, yeah.
So if you were to use a good original, then sometimes it might not be as good, but your medicine is really good. They will deem you as good too. But on the other hand, you try to save money, you may be very good, diagnose everything correctly, but because you are trying to save money, just be good-hearted and save money for the patient, and the effect may take longer to come in, then they think you're a lousy doctor.
But that's why the skill comes in. That's why the formula driver comes in.
Okay, the formula driver.
The
Formula One driver, right? Yeah.
The clinical acumen and the
Yes.
diagnosis. If you know this is a correct diagnosis,
Yes.
healing you faster or just extra 2 or 3 days probably doesn't really matter, right? As long as you say, I'm feeling good. So I guess when your patient supposed to come for appointment, they call up and say, I'd like to cancel my appointment because I'm feeling all better. So you know you've done a good job. Yeah.
That's right. Yeah.
Yeah.
Okay, since you're talking about that, I'm just curious. Okay, this is a bonus question. Do you feel that you're a better doctor if the patient call you up and cancel an appointment and say, "Oh, doc, I'm well now," or do you think you feel happier if the patient say, "Doc, I'm still not feeling better. I need to come in"?
I feel better for the former.
The first one.
Yeah,
You
the
prefer
second one I would say, okay, let me think about what's the cause of your problem. Yeah.
Right. Kenneth, what do you think? A or B?
Of course, definitely B lah. Yeah. Most
B.
of my patients,
They don't get well.
So you don't get better, I come
they
back to you again.
Okay, we don't. They get better after one time. Sorry.
Yeah.
See, what I'm trying to say is they get better after one time. I know that I'm confident in my diagnosis and my
Yes.
treatment.
Yes.
So generally, I do price myself a little bit more higher because I know they won't come back. So I don't get the repeat business.
It's not like a restaurateur or chef, right? You cook a nice dish, your patient eat it. This is so
they come back
good.
again,
I want to
they
come back
back.
again.
Yeah. No, I did public health, as you know. Actually, I find that interestingly, many doctors, especially GPs, they always think that the second version is better for their business because they can get more return customer. They get the clinic to be very crowded. But actually, I did modeling. I did computer modeling, and that is not true. Actually, the less you see the patient, the better your business. Yes. Besides charging a bit higher, right? The respect that they have for you, they will spread, because our business is not advertisement. Our business is really word of mouth. Yeah. So I have lots of patients, especially after seasons like Chinese New Year, holidays. Those where, because Singapore is multiracial and multi-religious, right? So things like occasions like Hari Raya, a lot of patients come in and they don't feel well, of course, but they will say, I'm recommended by so and so because during Hari Raya I went for visitation. They say, must see you, and that kind of thing, and that actually boosts the number of patients. So that's why if you keep seeing the same patient for the same problem, probably the conversation at home is different. They say, please don't see this doctor, this is horrible.
But I guess if the patient has the same problem, they
Yes.
continue to come back and see you, that means they do have a degree of trust.
I hope so.
That's what we all hope. Otherwise, they would go to another GP or another doctor, right, to get the problem fixed.
So if I charge a very low consult, like $3 and $5, lower than our barber, then easy house, then probably even them lousy patient will still come back, right? Yeah, so there's no pride in that, isn't it? But seriously, they do. When you have a big crowd of having the same patient again, you don't improve your business. Actually, you are just hogging hogging your business, the whole place, and choking up the business. And in the end, you yourself feel very, very, very defeated. You feel very discouraged. Why is the patient not getting better? Because doctors' mindset is always want the patient to be well, unlike what the public thinks.
I think as doctors, most of us are type A personality.
Yes.
We all want to do good things
Yes.
and be successful.
Correct.
So seeing a patient not come back after the problem is fixed,
But we are
that makes you
very
feel
happy.
good.
Yes, that's right.
Feel good factor probably is better than the money in the
That's
bank account,
right.
right? Yeah.
That's right. That's
Yeah.
right. Right. Yeah. So I think we have come to an end. I'm sure we have not expounded on every single factors that actually contribute to the cost of healthcare or rising cost of healthcare. But I hope to say give all of us, especially the audience, a glimpse of what goes into the cost.
Yeah.
And also maybe even some of the struggle that we have as doctors,
Yeah.
which is not known or not openly shared with the patient most of the time. Yeah. So with that, I think we just want to thank all of us here. And then hopefully the next podcast, if there are any other interesting things, we can always bring back the cost of healthcare again and talk about quality and all that. Like I said, there are lots and lots of things to talk about. But with that, we will leave it as here. So if there are any new comments, any other suggestions, any topics that you think we should cover, just put it in the comment sections, and then we will look at it, and then we'll study it as well, and not just talk off the cuff, but we will definitely prepare for it, and then so that we can share with all of you.
Yeah.
Any other last words?
The only thing I wanted to say is that I think patients nowadays,
Yes.
they really do value their time.
Yes.
And they are really, their time is very valuable to them. So definitely you want to find a good doctor so that you get better and you don't have to spend more time coming back.
Right. Yeah, true.
Yeah.
True. John?
Oh no, nothing to add.
Okay. With that, we thank you. Thank you so much
Thank
for
you, thank you.
watching. Yeah. Thank you.